Welcome to Mayo Medical Laboratories Hot Topics. These presentations provide short discussion of current topics and may be helpful to you in your practice. Our speaker for this program is Dr. Jane Hata, Director of the Clinical Microbiology Laboratory in the Department of Laboratory Medicine and Pathology at Mayo Clinic in Florida. Dr. Hata presents the latest information about an emerging infection, the Zika virus. Thank you, Dr. Hata, for presenting with us today.
Thank you for the introduction, and hello to today's participants. Today's Hot Topic presentation will discuss the emergence of Zika virus, a pathogen very much in the news. I should note that I have no commercial affiliations or other disclosures to make in connection with this presentation. In this presentation, I will discuss the characteristics of Zika virus and its pathogenic potential, with a special discussion on Zika virus and pregnancy, its emerging epidemiology, and symptoms and treatment of the disease. Appropriate use of current diagnostic methods will be discussed, and I will conclude with the strategies to prevent infection. Zika virus is a single-stranded RNA virus in the family Flaviviridae. Other members of this family include the yellow fever virus as well as West Nile virus. Zika is phylogenetically closely related to St. Louis encephalitis virus. Genomic data leads us to believe that there are two major lineages of Zika, African and Asian. Zika virus is most often transmitted via a mosquito vector, Aedes aegypti. Other Aedes species such as Aedes albopictus, Aedes henselae, and others have also been implicated. Remember that Aedes aegypti and albopictus are also responsible for transmission of dengue fever and the chikungunya virus as well. Zika virus breeds in the mosquito vector, which becomes infectious after a 10-day development period and remains so for life. Virus is spread to the next susceptible host when a mosquito takes a blood meal. Zika virus is generally not considered to be transmitted person to person. There is emerging evidence, however, of vertical transmission from a mother to the developing fetus. There has also been a single report of sexual transmission in 2008. There's also the theoretical possibility of transfusion-associated transmission of Zika via blood from a viremic donor. Zika virus was initially isolated in 1947 in sentinel rhesus monkeys used for yellow fever research in Uganda. The first human infections were then reported in 1952 in Uganda and Tanzania. The primary reservoir of Zika is currently unknown, although a primate reservoir has been suggested. Based on seroprevalence studies, anti-Zika antibodies have been found in rodents, zebras, and elephants, in addition to primates. In terms of confirmed human infections, sporadic cases were reported in Nigeria, Indonesia, Thailand, and Gabon from the early 1970s to 2010. There was a significant epidemic on the Micronesian island of Yap in 2007. This affected nearly 2% of the population, although the infection rate may have been much higher, but there were no hospitalizations or deaths reported. In late 2013, in French Polynesia, a significantly larger epidemic was noted. Nearly 11% of the population was affected, but again, no deaths were reported. However, Zika virus was carried to Japan, France, Easter Island, and New Caledonia via travelers from French Polynesia. 114 cases of Zika with self-sustained transmission occurred in New Caledonia, secondary to exposure to an infected traveler. In Brazil, late in 2014, a cluster of acute erythematous infections were noted from various regions in Brazil. Zika virus was identified in April of 2015, and genetic studies indicated an Asian lineage of Zika was involved. One thought is that the virus was brought by a visitor to the Soccer World Cup, held that year. The epidemic peaked in May of 2015 and affected all age groups. This pattern would be typical of spread of a new virus in a susceptible population. There was an equal distribution of disease between both males and females. 10 deaths are currently being investigated as potentially linked to Zika virus disease. These deaths were noted in conjunction with congenital abnormalities and in compromised hosts. Infections have also been confirmed in El Salvador, Guatemala, Colombia, Mexico, Panama, Paraguay, and Venezuela. Based on past history of viral spread, clearly there's a major concern for transmission of Zika virus in connection with the millions of spectators estimated to attend the 2016 Summer Olympic Games held in Rio de Janeiro. Here's a map of the geographic distribution of Zika virus taken from the Centers for Disease Control website, which is a great source of up-to-date information. This data is based on seroprevalence studies, epidemics, and tracking of individual cases, and it's changing quickly. We are now seeing cases through most of South and Central America, the Caribbean, and Puerto Rico. More than 10 cases have been confirmed in the United States. Zika is now a nationally reportable disease, and healthcare providers are encouraged to report suspected cases to their local or state health departments in order to facilitate diagnosis and epidemiologic study. Zika virus is considered a biosafety level 2 pathogen, so it may be handled routinely at the laboratory bench with appropriate personal protective equipment. As with other flaviviruses, replication of Zika virus is thought to occur in the cytoplasm or nuclei of human host dendritic cells that are located near the site of the bite from the infected mosquito. The virus then spreads to the lymph nodes and the bloodstream. Studies in mice have indicated that the Zika virus demonstrates tropism for neural tissue, resulting in neuronal degeneration and softening of the brain tissue. While this data is from mouse studies only, it may have implications in relation to the spike in infant microcephaly associated with Zika virus that we will discuss shortly. There has been an association noted between Zika virus infection and the occurrence of Guillain-Barré syndrome. Remember that this is an autoimmune-mediated syndrome that can occur after viral infections characterized by subacute or acute flaccid paralysis. This association was reported in the Zika outbreak in French Polynesia, with a total of 74 cases. There was a 20-fold increase in Guillain-Barré over the normal baseline prevalence, and there was a temporal relationship to the ongoing epidemic of Zika on that island. An increase in the number of individuals with Guillain-Barré has also been noted in Brazil, with 121 cases so far. Most of these cases have recovered on their own. However, the use of intravenous immunoglobulin has been of use in some instances. The effects of Zika virus on pregnant women and on the developing fetus is drawing a great deal of attention due to a 20-fold increase in reports of microcephaly in Brazilian infants. An uptick in the prevalence of microcephaly was also reported retrospectively after the French Polynesia epidemic of 2014. The relationship between Zika virus and microcephaly has not yet definitively been proven at this point. However, the association is being strengthened as we gather additional data. No other flaviviruses are generally considered to have this effect on fetal development. It's hypothesized that the highest risk of microcephaly may occur if the mother is infected with Zika during the first or second trimester of pregnancy. At birth, Zika virus can be detected in amniotic fluid of microcephalic infants. However, the maternal blood may be Zika RNA negative. Microcephaly is associated with reduced head circumference and gestational weight, brain atrophy and calcifications, and ocular cataracts, resulting in significant developmental issues and death in some cases. Importantly, mothers of severely affected infants were noted to be symptomatic for Zika virus during pregnancy, but only with mild disease. Healthcare providers should obtain a detailed travel history if exposure to Zika virus is suspected or if the mother demonstrates symptoms of infection. This also applies if the mother has resided in an area with active transmission of Zika. At this time, testing for Zika virus is not indicated for women without history of travel to or residence in an affected area. We will discuss specifics of testing momentarily. However, PCR or serologic testing of maternal serum in symptomatic patients can be performed. PCR testing of amniotic fluid can also be performed, and a positive result is suggestive of intrauterine infection. The serum and CSF of infants suspected of Zika virus infection may be tested for presence of IgM and viral RNA. Specimens should be collected from the umbilical cord or from the infant within 2 days of birth. In addition, the use of fetal ultrasound to monitor exposed infants, detect microcephaly, and determine management is recommended. Clearly, this is an evolving issue, and there's much work to be done in confirming the risk of Zika to the developing infant and firmly establishing cause and effect. A testing algorithm for management of pregnant women is available on the CDC Zika website and should be consulted for the most up-to-date recommendations. The incubation period of Zika virus in the human host is approximately 2 to 7 days after the bite from an infected mosquito. It's very important to note that in most individuals, the disease will be quite mild with only a few days of symptoms, and in many cases, people are completely asymptomatic. This will no doubt complicate the epidemiologic follow-up of suspected cases. In the 20% of individuals who are symptomatic, you may expect to see some mild fever, joint pain, a maculopapular rash that is occasionally itchy, and non-suppurative conjunctivitis. Occasionally, anorexia, vomiting, diarrhea, or constipation may occur. Headache, and in some cases retroorbital pain, has been reported. You may recognize many of these symptoms as being similar to dengue fever, which is also found in the geographic areas affected by Zika. Again, this will complicate the diagnostic picture. Severe disease requiring hospitalization and death is rare. Here's a comparison of symptoms noted in Zika virus infection, dengue virus infection, and chikungunya virus infection. These diseases demonstrate significant overlap in terms of mosquito vector transmission, geographic prevalence, and symptomology. Note that in Zika virus infection, when patients are symptomatic, characteristics such as edema of extremities, conjunctivitis, a maculopapular rash, and the absence of hemorrhage, leukopenia, and thrombocytopenia may assist in determining a diagnosis. The definitive diagnosis of Zika virus infection can only be made on the basis of laboratory testing. Diagnostic testing is currently recommended only for assessment of infection in individuals with a significant travel history to or residence in a Zika-affected area. Current testing methods for assessment of acute infection rely on serologic testing for presence of IgM to Zika virus and detection of Zika virus RNA in serum. Due to the many similarities in symptoms, providers should also consider testing for dengue and chikungunya in symptomatic patients. Zika virus IgM may not be detectable until 8 days after the onset of symptoms, but it will persist for several months. Confirmation of a positive IgM result will require the use of a plaque reduction assay to detect specific neutralizing antibody to Zika virus. A fourfold change between acute and convalescent neutralizing antibody titer is considered confirmatory of infection. It should be noted that with current assays, cross-reactivity with other flaviviruses leading to false positive results is an issue. Not only does this apply to previous infections with viruses such as St. Louis encephalitis or West Nile virus, but Zika serologic false positives could also occur in individuals who have received vaccinations for other flaviviruses such as yellow fever or Japanese encephalitis. Serologic testing can be performed on serum or cerebrospinal fluid. Testing of other specimen types may have to be considered on a case-by-case basis. Nucleic acid detection by reverse transcriptase polymerase chain reaction targeting the non-structural protein 5 genomic region is the primary means of diagnosis. RT-PCR testing for Zika is extremely sensitive and specific. However, due to the short period of viremia, serum samples must be collected within 7 days of the onset of symptoms. If the specimen can be collected within 7 days of illness onset, the use of PCR will nullify the cross-reactivity issues noted with serologic testing for Zika. Serum is the most common specimen type needed for PCR testing, although other specimen types such as CSF, amniotic fluid, tissue, or urine may be considered. Here are some factors to consider if your laboratory needs to pursue Zika virus testing. At this time, no commercial test is currently available. It is very important to have a conversation with your local or state Department of Health prior to specimen submission in order to determine if testing is available and what samples are acceptable. The availability of testing will vary between states, so ask first. If you are submitting specimens for testing, you will need to supply the following information. It's helpful to know when samples were collected in relationship to symptoms and any pertinent travel, residence, or medical history. Consult the CDC Zika website for information on testing and submittal forms. A testing algorithm is available at the website listed on this slide. This, unfortunately, is a very brief slide. The treatment for Zika virus infections in symptomatic individuals consists of supportive care only, mainly comprised of rest and fluids. This may include acetaminophen for joint pain and headache, and antihistamines for an itchy rash. There are no antiviral treatments recommended, and there are no specific recommendations for treatment of Zika virus in pregnant women or microcephalic infants at this time. There is no vaccine for Zika virus currently available. Could Zika virus emerge in the United States? Absolutely, yes. Look at the parallels that we've seen with diseases like dengue and chikungunya. Due to its rapid spread outside of Asia and Africa, Zika is considered an emerging pathogen. We certainly have the Aedes mosquito vectors in the United States, and we certainly have travelers from infected areas. As the number of infected areas increase, the chances that we will encounter Zika locally will certainly increase as well. So it's very important to become educated on this topic and be aware of updates as the situation continues to change. There are specific travel recommendations in relation to the emergence of the Zika virus. These were issued in January of 2016 and are currently and continually being reevaluated. Be an informed traveler before you go. Recommendations will likely change, so consult the CDC travel page for the most up-to-date information. Most importantly, if you are pregnant, if at all possible, you should consider postponing travel to areas with reported Zika virus transmission. If you must travel, avoidance of mosquito bites and use of repellent will not only protect against Zika, but also protect against exposure to dengue, chikungunya, and malaria. Women who are trying to become pregnant should discuss risk of Zika with their medical provider before they travel. If you do become ill after travel to an endemic area, see your medical provider without delay and provide a specific travel history. If you are ill, protect yourself against mosquito bites in order to prevent the possibility of viral transmission to others. There are actions you can take to reduce mosquito exposure. Not only will this reduce the opportunity for exposure to Zika virus, but also to other viruses such as dengue and chikungunya. Most importantly, avoid mosquito bites if at all possible. This can be addressed by cleaning up the immediate environment and removing sources of water in discarded containers, old tires, or drainage ditches where mosquitoes breed. You should reduce the chances of being bitten by applying insecticides such as DEET or use permethrin-treated clothing. When used as directed, these methods are also safe for pregnant women. Barriers such as long pants, long sleeves, and window screens can reduce mosquito exposure. And finally, spraying or fogging of insecticides to kill adult mosquitoes may be employed. To summarize today's presentation, Zika virus is emerging throughout South America, Central America, and the Caribbean. There have been isolated cases reported recently in the United States. Most infections are asymptomatic or mild, consisting of fever, arthralgia, and headache. Symptoms can be confused with dengue or chikungunya. Conjunctivitis, extremity edema, and rash are more likely to occur in association with Zika virus, and only supportive treatment is available. In terms of testing, diagnostic testing is available at the CDC or certain state departments of health. It's strongly advised to communicate with your local or state lab before submitting specimens. Testing with RT-PCR is only appropriate for specimens collected less than 7 days after the onset of symptoms due to the very short period of viremia. Serologic detection of IgM may be of use if specimens are collected greater than 7 days after the onset of symptoms. According to the current CDC testing protocols, a confirmatory plaque reduction neutralization test will be performed if the screening IgM test is positive. Be aware of the possibility of serologic cross-reactivity with other flaviviruses such as dengue or West Nile virus, which can occur. Disease due to Zika virus is generally mild or without symptoms. Rarely, more severe cases can result in manifestations such as Guillain-Barré syndrome. At this time, one of our great concerns is the seeming association of Zika virus infection in pregnancy and the occurrence of microcephaly in infants. This is an emerging situation, and our understanding of this issue will likely change rapidly. If you are traveling to an area in which Zika has been reported, avoid mosquito bites. If you are ill, avoid mosquito bites in order to prevent transmission to others. Finally, there are specific travel recommendations that have been issued by the CDC in response to this epidemic. Women who are pregnant are currently advised against travel to areas where Zika transmission is ongoing. These recommendations may change over time, so consult the CDC travel page for the most up-to-date information. This concludes today's discussion of Zika virus. Thank you very much for your attention, and good day.